All right. So, welcome to JOWMA's Women's Health Committee webinar on menopause. I'm Dr. Denise Moses. I'm an OBGYN, board certified, and I work in Queens, New York. We created the Jewish Orthodox Women's Medical Association, also known as JOWMA, as a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our department, the Women's Health Committee, was created with the goal of increasing access to women's health education to the Orthodox community, thereby empowering women to be better equipped as self advocates. We believe it's important to know about our bodies, know what to expect when women see their doctors, and know which questions to ask. If you haven't done so already, please take a minute or two to fill out the pre webinar survey. The link to the survey is in the chat, and there's a QR code that's posted currently. There will also be a post-webinar survey, which you will receive after the webinar. Please try to fill out both surveys, as this will help us conduct research on this education. Tonight, we will be covering menopause. We'll be addressing the following topics: general health and screening guidelines in women after age 40, menopausal symptoms and treatment options, osteoporosis and prevention, as well as urinary incontinence and pelvic organ prolapse. We also like to remind you that this forum is not a substitute for getting individualized medical advice from your doctor. There will be a Q&A at the end of the event. Please keep questions broad. All questions should be posted in the question box. If you would like your questions to remain anonymous, please hit the Remain Anonymous button. Your presence on this webinar is completely anonymous. Your video and voice are not enabled, and attendees cannot be viewed. Our first speaker is Dr. Kingsburg from Milli, our sponsor for tonight's event. Milli will be raffling a vaginal dilator and telehealth session to one lucky attendee. If you would like to be entered, please fill out the form seen in the chat. Okay. Dr. Kingsburg.
Well, hello, everyone. It is actually such an honor to be here with all of you tonight. And now, as a psychologist, and I am a psychologist, and I lead a behavioral medicine division in an academic OBGYN department. I'm also the past president of, sorry, I have to share my screen. Okay, here we go. Sorry about that. So I am let me see if I can get it. I'm a clinical psychologist, and I am the past president of the North American Menopause Society. And so, as such, I am actually very honored to represent Milli Medical and Materna Medical and consult for them. And I'm excited to give this talk to you because this is a one-of-a-kind innovation of an expandable dilator, and I'm going to tell you why this is really exciting. I happen to recommend dilators in my practice a great deal, and they're very useful for women for a variety of reasons who have pain or anxiety about inserting anything into their vagina, whether it's a tampon or whether it's during sexual activity. Now, who's my most common patient? It's actually a postmenopausal woman who's developed pain due to the loss of estrogen in her vaginal tissue. And as a result, she develops this reflexive tightening of the vaginal muscles as the vagina tries to reflexively protect its owner, if you will, from anticipatory pain. Now, many of you may actually already experience this. You have dryness, you have pain with insertion, but you may not know that all the rest of you out there are also suffering. And most of you don't talk to each other about this, and most of you don't talk to your healthcare provider about it. So the fact is that this is the unspoken symptom of menopause. Now, of the 64 million postmenopausal women in the US today, at least 50%, and probably more like 70 to 80%, suffer from what we now call genitourinary syndrome of menopause. Large name, GSM, call it that for short, but it's better than the old name vulvovaginal atrophy. Most women don't like to think about their vaginas as atrophy. But GSM is also a relatively unknown thing for most postmenopausal women. Everyone knows the hallmark symptoms of menopause: hot flashes and night sweats. But most women don't realize that vaginal dryness and painful intercourse are almost as common and worse. While hot flashes and night sweats will eventually go away, they might seem like they won't, but they eventually go away, whether you treat them or not. GSM is chronic and progressive and needs to be treated in order to be resolved. Let me show you, so here's the term GSM, and it's due to loss of estrogen and worsens over time. And let me show you, I think a picture is worth 1,000 words, the difference between the tissue of a vagina that has estrogen in it and the tissue that does not. On the left, you can see a healthy, well-estrogenized vagina, and you can see the tissue and the lining is very thick and buoyant and flexible. On the right, you can see the tissue of a woman who has very little, if any, estrogen in her vagina, and it essentially looks like the Sahara Desert. Most women will say to me when I show them this picture, well, no wonder it hurts when I try to have sex. This is the problem. This is treatable, but it is very common and goes unspoken and untreated. That's the bad news. Now, the good news is we actually have many safe and effective treatments for GSM. And I could spend my 5 minutes just talking about all the wonderful treatments we have, but what I really want to talk about is to use my 5 minutes to talk about the fact that no matter what, whether you treat it or you don't, once you develop GSM, the vaginal muscles will tighten reflexively in order to prevent any attempt at penetration, and the use of dilator therapy, even with a treated vagina, is the most effective way to essentially undo that reflexive tightening. So I will tell you, and Dr. Wienerman will go on and tell you, there are many safe and effective local hormone therapies, laser treatments, vaginal DHEA, oral osbemophene, pelvic floor physical therapy, but it is the dilator therapy that really addresses the anticipatory anxiety no matter what the cause. So vaginal dilation therapy is really a cognitive behavioral strategy that you do at home in your own private home that allows you to, under your own control, slowly stretch your vagina without pain and to teach your vagina that penetration is safe again. Essentially, let's call it yoga for your vagina. The idea is that, well, plastic dilators have been around for a very long time, decades, if you will. But what's unique about the Milli is that you can actually insert it at its most narrow diameter. And then once it's in the vagina, you, under your own control, can slowly, 1 millimeter at a time, that's why it's called the Milli, expand so that there's no anxiety about putting in a large dilator. You can put it in and gradually increase the diameter at your pace with no pain. The rule of thumb is no pain. You slowly, gradually, under your control, in your privacy, allow the dilator to stretch. It also has a vibration capacity that allows you to allow more blood flow, to stimulate blood flow, and helps with the relaxing of the muscles. So with that, please ask your doctor if vaginal dilation therapy is for you. Materna has partnered with JOWMA to give away a Milli and a complimentary pelvic floor physical therapy telehealth session, so please stay tuned for that. In the meantime, thank you for your attention to my 5 minutes, and don't hesitate to reach out and ask questions if you're interested. Thank you very much. Stop sharing.
All right. Thank you so much, Dr. Kingsburg. That was very interesting. And, for the winner, if you want to be entered into the raffle, please follow the link in the chat. Next, we will be hearing from Dr. Wienerman. Dr. Wienerman, Rachel Wienerman, MD, is a physician specializing in reproductive endocrinology and infertility. She received her medical degree from Harvard Medical School and completed her OBGYN residency at NYU and fertility fellowship at the University of Pennsylvania. She is currently an assistant professor at University Hospital Case Western Reserve University in Cleveland, Ohio, where she specializes in infertility and reproductive issues. Her research focuses on the impact of assisted reproductive technology on women's health.
Hello, everybody. Thank you so much for the opportunity to speak tonight. And I'm very excited to talk to you about health beyond the reproductive years. It was great to hear from Dr. Kingsburg. We worked together at University Hospital, so you got a little preview of some of the things we're going to be talking about today. And I have no disclosures. So our learning objectives today are going to be talking about health screening, menopause, and osteoporosis. So all the things that you should know about your health, what we call beyond the reproductive years in middle age and beyond. So the average life expectancy for a woman is 80 years. I brought a picture of Queen Elizabeth to show you how productive you can be, towards the end of your life, and how you can make a productive use of life well beyond 80 years. But the average age of menopause is 51. So there is a long time to live after the reproductive years that, for some women can be half their life spent after menopause. Fertility declines about 10 years prior. And health needs are different in middle age and beyond. And it's very important to recognize that. It's very important for doctors to recognize it. It's very important for patients to recognize it. So educating you is very important as the first step to creating a partnership between you and your physician to create a healthy plan for you for a very productive time in your life. So the first thing I want to talk about is what you should know when you visit your doctor. So in terms of general health screening, there are a few topics that you will probably be addressing at your doctor's visit. So first of all, how often should you see a doctor? Generally, I recommend at least annually. Now, if you have a medical condition or specific issues to discuss, this might be more frequent. Now, what will the doctor be talking to you about? So cancer screening at every visit, general health screening, and preventative care. Now, what should you ask? So I want to emphasize this. Do not be afraid to ask about anything. I think Dr. Kingsburg brought up one topic that patients don't often ask, which is sexual health. But in general, anything should be fair game in the doctor's office. Now, if you don't ask about it, the doctor may not know to ask about it, and then it doesn't get discussed. So really, do not be afraid to ask about anything. What type of cancer screening will be assessed at your visit? So breast cancer is very common among women as one of the most common cancers. And so a breast exam is going to be done in every visit. And mammograms, which are a specialized x-ray to look for breast cancers, should start for most women at age 40. There was some controversy about screening between the ages of 40 and 50, and that's something that you can discuss, but many organizations still recommend age 40 and to be done annually. Colon cancer, sorry, my light went off. Should start at age 50, and that's with a colonoscopy. And then skin checks are very important to screen for for skin cancer. That's something that some people don't necessarily think about when they go to visit the doctor. But if you're at high risk for skin cancer, you should have a screening every year. Pap smears are what we use to screen for cervical cancer. Now, in the past, Pap smears were done every year. So many women think that their visit to the gynecologist will automatically include a Pap smear. This is no longer true. So we have learned that Pap smears can be spaced out if they have been normal in the past. Now, we've also combined Pap smears with HPV testing, which tests for something called the human papillomavirus. If you have a negative Pap smear and a negative HPV test, you can actually space out your Pap smear to every 5 years. Or if you have just a Pap smear, it can be spaced out to every 3 years. And then you can stop screening at age 65 if your Paps have all been normal. Now, if you've had your uterus removed, you can stop your Pap smear screening as long as you've also had your cervix removed. Turn my light on one more time. let's talk about preventative care. What else is the doctor going to be talking about at your visit? So heart disease is something that your doctor may be screening for with a cholesterol panel and sugar assessment. And then the doctor may also check for thyroid and vitamin D levels. This is based on risk factors. Osteoporosis, we're going to talk about later, is usually started at around age 65 or younger if you have risk factors, and that's with a DEXA scan. Now, vaccines. We've talked a lot about vaccines recently because of the COVID vaccine. However, there are more vaccines that you should be aware of because there are certain vaccines that you actually need as an adult. There are some vaccines that you should get yearly, and there are certain vaccines that you only get as an adult. So, for example, the flu vaccine. We've talked a lot about COVID and how it compares to the flu. We have a flu vaccine that we should get every year. So all adults should get a flu vaccine yearly. And then Tdap, which is our tetanus vaccine, you need a booster every 10 years. It is very interesting how quickly 10 years can go by. You may forget when you're due for this, so sometimes you have to check in with your doctor, but that should be every 10 years. Now, the herpes zoster vaccine is the same virus that causes chickenpox. It can also cause a syndrome called herpes zoster. So when you are 50, you should get this vaccine. And the pneumococcal vaccine is recommended for adults 65 and older. When you're at the doctor's office, there are certain things that your doctor should also be screening you for. Now, these may not seem obvious, but like I said, nothing is off limits in the doctor's office. So your doctor should be screening you for depression, anxiety, substance abuse, alcohol abuse, intimate partner violence, or what we call domestic abuse, and STD risks. And in turn, like I said before, you should not be afraid to ask about anything. So now let's talk about menopause. And my goal for this part of the talk is for you to understand your body and your options. So first of all, what is menopause? So as we mentioned before, well, Dr. Kingsburg mentioned, menopause is due to a decline in estrogen production. So let's talk about that more. Estrogen is the hormone that is produced by your ovaries. What happens in women's bodies is that the ovaries produce eggs. Now, a woman is born with all of the eggs she'll ever have in her ovaries at the time of birth. Every month, you use up a group of these eggs. And when you ovulate, your ovary also produces hormones. The hormones that your ovary produces is called estrogen. And then after ovulation, a different hormone called progesterone. The role of these hormones is actually to make the uterus ready for pregnancy. Now, in the meantime, what estrogen and progesterone do is thicken the uterine lining. And if you're not pregnant, after the progesterone stops, you actually get a period. So why do you get a period every month? Because you've ovulated and produced hormones that get the uterus ready for pregnancy, then those hormones are taken away. Now, what happens is as a woman gets older, you have fewer eggs left in your ovary. And eventually, you don't have any eggs left in the ovary, or very few eggs left in the ovary, and there's not enough eggs left to produce the hormones that make you ovulate and that produce a period. So when the follicular pool has been depleted and there's very, very few eggs left, that's called menopause. So we can see here is that a woman is born with about 1 million eggs, and towards the end of her reproductive years, it's down to almost none. So in essence, menopause is a decline in estrogen production due to a depletion of eggs in the ovary. This leads, as we said, to decreased hormone production. Now, you may have heard of something called FSH. FSH is what happens in the brain as a response to the low estrogen levels. So high FSH levels are present in menopause as a response to low estrogen from the ovary. Many of the symptoms of the menopausal transition are due to the decline in estrogen and hormonal fluctuations. Now, once the body has fully adjusted to the lack of estrogen production, some of the symptoms go away. Some women get used to this low estrogen state, and so the body can adjust to it. However, this can take years, and not all of the symptoms go away. So how do we define menopause? So perimenopause, or the menopausal transition, is what we say as the beginning of the menopausal era. This is defined by irregular periods. So the pattern of menstrual cycles during the perimenopausal period really varies. So women may experience shorter cycles, they may experience longer cycles, heavier bleeding is very common, or lighter bleeding. The pattern is very unpredictable. And it can also go on for years. The average age of perimenopause is 47. And then we define menopause as when the periods have stopped altogether. And we define it retrospectively. So you have to have 12 months of no periods, and that defines menopause. And the average age is 51. Now, the symptoms of menopause, Dr. Kingsburg hinted to some of these, but hot flashes are really the most common symptom that a lot of women talk about and a lot of women experience. We call this vasomotor symptoms, and it is caused by hormonal fluctuations in the body. So the hormonal fluctuations, and specifically the low estrogen levels, but also the fluctuations in estrogen and other hormones, affect the body's temperature regulation system. So you end up with this feeling of heat passing through the body like a wave. And it often happens at night. It can be very, very disruptive to women. Now, interestingly, about 80% of women will experience hot flashes during perimenopause and menopause. Only 20 to 30% will seek treatment from their doctor or discuss it with their doctor. So it is something that women need to know about and know that treatment options exist. Like we said, hot flashes often happen at night, so it is associated with sleep disturbances. But even without hot flashes, menopause can affect sleep. Menopause is also associated with depression, and this is hormonally related. Menopause is also associated with changes in sexual function. So this is due to a few reasons. So women's libido can be affected by the changes in hormones that happen during menopause. And then estrogen also leads to vaginal dryness, or what you heard about before, the genitourinary syndrome of menopause. So that vaginal dryness is specifically due to low estrogen levels on the vaginal tissue. Menopause can also lead to changes in cognitive function and joint pain. Now, long-term, when you have these low estrogen levels, it can lead to bone loss, cardiovascular effects, dementia, and skin and body changes. So what are your options? Hormone replacement therapy is one of the mainstays of treatment for menopause. It's extremely effective at treating the symptoms of perimenopause or menopause, and it replaces the estrogen that has declined. Now, if you take hormone replacement therapy and have a uterus, you need to also take progesterone to protect the uterine lining from developing uterine cancer. It is indicated for the symptom relief in perimenopause or early menopause. And the benefits include symptom improvement and bone health. However, there are risks, including possible increases in blood clots and stroke and possible breast cancer risks. And it is not indicated for cardiovascular protection or disease protection. Now, we have been talking about natural menopause. It is important to distinguish between this and surgical menopause. So women who've had their ovaries removed prior to age 50 should be on a hormone replacement therapy until the age of 50, unless there's a specific reason not to, such as breast cancer. That is very different than natural menopause. So hormone replacement therapy has been the subject of controversy, and a lot of this has been due to the Women's Health Initiative trial that was published in 2002. So that was a study of estrogen and progesterone, or estrogen alone, for the prevention of cardiac disease. Essentially, they randomized patients in menopause to get hormone replacement therapy or not. And these are women who are between the ages of 50 and 79. Not all of them were symptomatic. And the goal was to improve health. Now, surprisingly, the therapy actually increased their risks. And this really questioned whether HRT was safe. Since then, however, we have learned a lot. Age matters and indication matters when giving hormone replacement therapy. So our current practice has learned a lot since that time. So hormone replacement therapy can be beneficial and low risk if given to younger women shortly after the onset of menopausal symptoms. Ideally, you start at the onset of symptoms under the age of 60, and the duration of use should ideally be less than 5 to 10 years. Now, we recommend vaginal estrogen only for local symptoms, and HRT is not recommended if you have a history of breast cancer or heart disease. Now, risks should be individualized if there are risk factors for these. So what are your options for HRT? So the mainstay of HRT is estrogen, and this can be taken orally in the form of pills or transdermally like a patch. Now, if you have a uterus, you also need progesterone. This can be naturally in the form of pills or synthetic. You can take it cyclically, meaning only for like 12 days a month, in which case you'll get a period, or continuous, or it can even be in the form of an IUD. A lot of women don't know about this, but a progestin IUD can be a great way to get progestin during HRT. Vaginal estrogen is a great treatment. Local estrogen provides very little systemic hormone, and it can be very helpful for vaginal atrophy. It's a great option for women with local symptoms, even those who can't take HRT, and multiple formulations are available. There are other hormone options available for menopause, such as ospemifene, which is an oral medication for vaginal atrophy, prasterone, which is vaginal DHEA, which is non-estrogen, and there are some non-hormonal options like antidepressants, gabapentin, and another medication called oxybutynin. Now, there are some treatments down the pipeline. For example, medications for hot flashes that target or are called candy neurons on the brain. This is really exciting pharmacology, so please stay tuned. I'm going to skip this slide just for time. So next we're going to talk about osteoporosis. So what is osteoporosis? So as estrogen levels decline in menopause, then bone health declines, because estrogen is really important for bone health. And when you have low estrogen, then you're at higher risk of low bone density. Now, mild low bone density is called osteopenia, and significant low bone density is called osteoporosis. And that's where you've kind of heard that term, osteoporosis. And the risk of this is fracture. Family history and other risk factors also play a role. So how do we screen for osteoporosis? First of all, it's recommended for all women ages 65 or older, and any postmenopausal woman less than 65 who has risk factors. We screen with a DEXA scan, which is a specialized X-ray that assesses the bone density of the hip and spine and assesses future fracture risk. It reports out a T-score, which compares your risk to a standard. Now, how do you prevent and treat osteoporosis? So there's certain vitamins that you can take, calcium supplementation, at least 1,200 milligrams a day if you have low bone density, and vitamin D, 800 to 1,000 IU a day. Now, weight-bearing exercise is really important. That is very important for bone health. And then medications include bisphosphonates, which are the main class of medications we use, but there are other treatments as well. Now, hormone replacement therapy is not first-line treatment for osteoporosis in postmenopausal women. However, women who are on hormone replacement therapy for other reasons will see benefits for treatment of osteoporosis.
2-minute warning. Oh.
So conclusions, it's important to maintain regular contact with your primary care physician or OBGYN to discuss changing health needs as you enter your post-reproductive years. Now, there are many options that exist and new ones are always being developed. So it is very important that nothing be off the table. That's like the main takeaway message that I want you guys to get from my lecture, because you may think that your symptom is common, You may think that every woman has it, or you may think that your symptoms uncommon and that nobody shares your experiences. The bottom line is that unless you discuss what you're experiencing with your physician, you won't know what options are available to you and what options you have. And the options that are available are probably more than you think. So I hope that you enjoyed this lecture, and I look forward to answering your questions at the end.
All right. Thank you so much for that great information, Dr. Wienerman. Our next speaker is Dr. Allison Poland. She's a female urologist with fellowship training in female pelvic medicine and reconstructive surgery, also known as urogynecology. Dr. Poland completed her undergraduate degree in biomedical engineering at Yale University before going on to medical school at Columbia University. She completed her general surgery internship and urology residency at Mount Sinai Hospital before going on to fellowship at Georgetown University. Dr. Poland is one of the few urologists in the country with cross-specialty training in a gynecological-based female pelvic medicine and reconstructive surgery fellowship. She is board certified in both urology and female pelvic medicine and reconstructive surgery and has extensive training in minimally invasive surgical techniques. Dr. Poland has a strong research background with a special interest in women's sexual health. She has been recognized for her research on a national level with multiple presentations at national scientific meetings. Dr. Poland.
Thank you so much for that nice introduction, and thank you for inviting me to speak about prolapse and incontinence. I'm really passionate about these topics, and so I'm excited to share this information with you. I'm just trying to advance the screen, and I'm not sure why it's not allowing me to do that. Give me 1 second. There we go. So my disclosures are related to funding for research that I'm involved with. And the learning objectives are to learn about prolapse and incontinence. I'm going to start by talking about prolapse and specifically the different kinds of prolapse: a cystocele, which is an anterior prolapse, apical prolapse, which is the top of the vagina, and a rectocele, which is posterior prolapse. And then we're going to talk about incontinence and the different types of incontinence. There's stress incontinence and urge incontinence. I want to start by saying, similar to some of the things that Dr. Wienerman said, that these are very common problems. 1 in 4 women has prolapse or incontinence in their lifetimes, and this is more common with increased number of pregnancies and deliveries. And I have a lot of patients who come to me and say, I'm only 30, I'm not supposed to be leaking urine until I'm older. Or, well, I'm only 50 or I'm only 60, but this is something that's supposed to happen to women who are much older than me. But the truth is that these are problems that are common from childbearing age on through past menopause. But just because they're common doesn't mean that it's normal, and it doesn't mean that there's nothing that we can do about it. And the treatment options range from conservative treatments like Kegel exercises to invasive treatments like surgery. And there are also patients who have these issues and choose not to have treatment, and that's okay too, because for the most part, these are quality of life issues. And so I often say to patients, if it doesn't bother you, it doesn't bother me. I want to start with a little background in the field, in case you've never heard of urogynecology. Specialization in the fields where urology and gynecology meet has been around for years. Urologists called it female urology, gynecologists called it urogynecology, and in 2011, they came together to create the board-certified subspecialty called female pelvic medicine and reconstructive surgery, or FPMRS. So while you could see a general gynecologist for some of these issues, and you could see a general urologist for others, the people who are best treated or best suited to treat all of these issues are specialists in urogynecology, or FPMRS. Prolapse is when 1 or more of the pelvic organs falls down into the opening of the vagina. It's more common after vaginal deliveries and with other things that cause repeated straining, like a chronic cough or chronic constipation. Women will sometimes feel a pressure or heaviness, and if the prolapse is advanced, they'll actually see something coming out of the vagina. Some women will describe it like seeing a ball coming out of the vagina or feeling like there's a tampon that's partially stuck out of the vagina. And some women will also have problems getting the urine or the stool to come out when the prolapse is down. Let's start with some basic anatomy. Every vagina has a front, a back, and a top. In the front is the bladder that holds the urine. The top is the uterus that holds the babies. And the back is the rectum, which holds the stool. And each of these compartments can prolapse or herniate into the vagina, leading to a cystocele, which is the bladder prolapsing, a apical prolapse, which is the uterus prolapsing if there's a uterus, or in the intestines if there is no uterus and the patient's had a hysterectomy, or a posterior prolapse or a rectocele, which is the back of the vagina prolapsing. So here's a picture of an apical prolapse with the uterus in place. So apical means the top, and here you can see in this extreme example, the uterus comes all the way out through the vaginal opening when the patient bears down. Now you're probably thinking, well, the treatment for that when the uterus is falling down is just, well, take out the uterus. But just removing the uterus alone actually doesn't treat the prolapse. In fact, the patients will end up with a prolapse of what's called an enterocele, or the small bowel, which is coming out through the opening of the vagina. In fact, actually just having a hysterectomy without an additional procedure to the top of the vagina can increase the risk of prolapse. The next form of prolapse I want to talk about is an anterior prolapse or a cystocele, basically the bladder coming down into the vagina. Patients who have this may not be able to empty their bladder completely because the urine can't really go up against gravity and then out through the urethra, which is the tube where the urine comes out. And so when the urine doesn't empty well, the patients can end up leaking urine and getting urinary tract infections. Another complication with a cystocele or an anterior prolapse is a kinking of the ureters or the kidney tubes. And that can actually cause urine to back up to the kidneys. And this is a pretty rare complication, but it's one of the few situations in which I would tell a patient they really have to do something to treat their prolapse, as opposed to really only doing something if you're bothered. And here you can see a posterior prolapse or a rectocele. Patients with a rectocele may complain of constipation due to stool trapping. Basically, the stool ends up getting trapped in this outpouching of rectum into the vagina. And basically, the patients can't get the stool out, and they may need to, in fact, put their finger into the vagina to sort of push everything back in place to get the stool to pass through the anus. And I want to point out that that's different from a rectal prolapse, which is a prolapse through the anus. So what can we do to treat these kind of problems? The easiest treatment for pelvic organ prolapse is pelvic floor exercise. This is something you can try at home. Or how about this? Everybody try it with me now. You basically squeeze the muscles of your vagina and lift as if you're almost trying to pull your vagina up to your belly button. And I know that sounds weird, but try it now. Everybody try to do these squeeze and lift. It's really not hard, and it's something you can do while you're doing other things. And I usually say to patients, do it while you brush your teeth. That way you'll remember to do it in the morning and you'll remember to do it in the evening. And if you do it sort of, squeeze and lift and release and squeeze and lift and release, and you can do that 10 times in a row. And if you're doing it when you brush your teeth, you're not going to forget to do it. These kind of exercises have shown to help prolapse with patients feeling less bothered by the prolapse and even having small improvements in the severity of the prolapse. For patients with a prolapse that's causing symptoms but not extending past the opening of the vagina, I think this is a really great first option. But it's important to do these exercises right, because if you do it wrong or if you overdo it, you can actually end up with a muscle spasm in the vagina, which causes pain, burning when you urinate, or frequent urination. And that's why, for some patients, I recommend getting some more instruction. This can be done in the form of biofeedback, which is often done by a nurse in your doctor's office, where a probe is placed into the vagina to help you isolate the muscles and teach you to squeeze them correctly. Or even better than that is seeing a pelvic floor physical therapist. And that's a physical therapist who specializes in the muscles around the pelvis and the vagina and will examine how you walk, how you stand, how you breathe, and how all of these things affect your pelvic floor. The pelvic floor physical therapist will also do a vaginal exam to see how those muscles are working and which ones aren't working well, and then give you exercises to do at home. You can't just see any physical therapist for this. You really have to see a specialist, because most physical therapists don't train in how to do a pelvic exam or a vaginal exam. So just like you wouldn't see someone for your shoulder who doesn't know how to examine a shoulder, you shouldn't see someone for your pelvic floor who doesn't know how to do a pelvic exam. The other thing I want to mention is that the exercises really work when you're doing them, but if you sort of stop doing them, the prolapse symptoms may come back. And so that's why people will often move on to other options. So the next option is a pessary. And this image depicts treatment of prolapse in the Middle Ages, where they used balls of yarn and stone as pessaries. And we still do this today, just not with yarn. A pessary is a space-occupying device placed in the vagina to support the pelvic organs. There are different shapes and sizes used for different types of prolapse. I know some of these look strange, but most often I just use the one that looks like a ring. It gets folded in half and then put into the vagina. And here you can see the pessary in place. It basically supports the pelvic options and the pelvic organs, and it's a great option for elderly patients who aren't surgical, who aren't interested in surgery, or for young women who are interested in future childbearing. The patients can take it in and out on their own, and some women only use it when needed, but other women use it daily or only remove it for intercourse. And for women who are not sexually active and choose not to be managing the pessary on their own, they just come see me once every 3 months, and I take it out, wash it, make sure everything looks okay, and put it back in again. So the next treatment I want to talk about is surgery. As I said, I don't usually recommend surgery until a woman has completed childbearing. And the reason for that is because prolapse usually comes back with another pregnancy, and especially with a vaginal delivery. So it doesn't really make sense to do surgery and then have the prolapse come right back. So that's why for women who are still planning to have additional children, I often recommend a pessary. But when someone's completed childbearing, surgery can be a great option. Let's go back to the anatomy. Every vagina has a front, a back, and a top. And so if we're doing reconstructive surgery, we need to address each of these areas. Surgery for prolapse can be done from different approaches. Oh, I'm sorry, I think I just made this much bigger. Let me make it smaller. Okay. So surgery can be done from different approaches. It can be done through the vagina, which is called transvaginal surgery, or through the belly, which is called abdominal surgery. And when you use the tiny incisions through the belly, that's called laparoscopic surgery. And when you use the robot to control the instruments that go through the tiny incisions in the belly, that's called robotic surgery. The most important thing to talk about in terms of the prolapse is how we manage the top of the vagina, or the apex. The uterus sits at the top of the vagina, and repair of this apical compartment can be done with or without a hysterectomy. But a hysterectomy is often recommended because that results in a more durable repair. So what are our options, specifically for repair of the apex? A sacral colpopexy is the most durable repair. I'm going to show a picture here. And basically, a sacral colpopexy is done by sewing a piece of mesh or plastic fabric to the front and the back of the vagina and up to the tailbone. This is not transvaginal mesh, which means mesh placed through the vagina for prolapse. Rather, this mesh is placed through the belly, so it's more like mesh for a hernia repair. And this is the most durable repair because rather than relying on the strength of the patient's own tissues, it's actually relying on the strength of the plastic fabric. The second two repairs I listed are what are called native tissue repairs, which is to say they're just done with stitches that dissolve on their own. And a uterosacral ligament suspension is usually done at the time of hysterectomy, which is removing the uterus. And basically that sews the top of the vagina up to some of the strong tissue inside the pelvis. And that can be done through the vagina, which is transvaginally, or through the belly. Whereas the last option, the sacrospinous ligament fixation, is done only through the vagina because you don't need to be in the belly at all for that procedure. So there's no need to do it from an abdominal or a laparoscopic approach. Again, the sacral colpopexy image. And the question is, why should a patient pick one option or another? You know, you might say, well, mesh is stronger, so I'd love to have something that's going to last me longer. But that sort of brings us to the transvaginal mesh discussion. Before we jump there, though, I do want to say mesh is going to last longer. And so I usually tell patients who pick a mesh augmented repair that it's going to last them about 20 years. Whereas I say to patients who are picking a repair that is just with stitches that dissolve on their own, that it's going to last for a shorter period of time. And that's more like maybe 10 years. So you sort of say, well, if I have to balance the length of time versus the problems with the mesh, well, what are the problems with the mesh? And so there's a chance that you could have an infection or a reaction, or the biggest concern is actually an erosion or an exposure, basically the mesh going somewhere it's not supposed to be. So the mesh could go into the bladder, which would be a problem that would need to be removed, or the rectum, again, a problem that might need to be removed. And so, you know, that's why I will often say that maybe we should do something else. The other place that the mesh can go is just into the vagina, which is really not such a big problem. Basically, as you get older, the vagina gets thinner, just like the tissue throughout the rest of the body can sometimes get a little bit thinner. And so the mesh can actually poke through that tissue. But one of the things that Dr. Wienerman mentioned, the vaginal estrogen, can be very effective in kind of helping the vagina to get sort of more healthy so that it can grow back over the mesh. And here you can see some pictures that I'm sure you've seen if you watch TV or ride the subway. It's basically hard to avoid ads like these from people looking to say, do you need to sue your doctor for transvaginal mesh? But what's it really all about? So transvaginal mesh is mesh placed through the vagina for prolapse. And like I said, this is different from the sacrocolpopexy mesh, which is mesh placed through the belly for prolapse. And mesh has actually been used by general surgeons for years. And the concept of mesh use for pelvic organ prolapse began in the 1990s because there were some big studies that came out showing the risk of reoperation with just using stitches alone could be as high as 30%. And in order to reduce the risk of relapse, people said, well, why don't we use some mesh? But the problem is that industry was sort of pushing doctors to use mesh, with some doctors, not really knowing, not really doing prolapse repairs otherwise. And so the industry's push was sort of ahead of the evidence. And when later studies came out, they found that the mesh did help lift up the prolapse, but the difference wasn't so great that the patients noticed a difference. And since this is all quality of life surgery, as I say, if it doesn't bother you, it doesn't bother me, well, then there's no need to add mesh if the patients don't notice a difference. So because of the issues with the transvaginal mesh, the FDA put out a public health notification, first in 2008 and then in 2011, stating that serious complications from transvaginal mesh were not rare. And this very much altered patient perception and also led to major changes in practice. And then in 2019, the FDA actually banned the use of, or rather banned the selling of transvaginal mesh for prolapse. So transvaginal mesh is no longer used. As I mentioned before, this is different from sacrocolpopexy mesh, which is mesh placed through the belly to lift the prolapse. And it's also different from a sling mesh, which I'm going to discuss again a little bit more later. The last surgery I want to mention is what's called a colpochliesis, which is a closing of the vagina. Basically, you make the hole of the vagina smaller so that nothing can fall out. And this is done for patients who are not sexually active and don't plan to be in the future. Everything looks normal from the outside and patients can urinate normally, but the vagina is closed in such a way that you would not be able to have penetrative intercourse. So in summary, prolapse repair can be done via a transvaginal approach or an abdominal laparoscopic or robotic approach. It can be done with a hysterectomy or without, which is called uterine sparing, and it can be done with mesh augmentation, which is a sacrocolpopexy, or without mesh, which is using stitches alone. Before we move on from prolapse, I want to touch on sexual function. The first thing I want to say is that having sex does not make prolapse worse. So if you want to have sex, there is no need to be afraid to do it if you have prolapse. If you have prolapse, you may notice it during sex with some more pressure or sometimes a feeling of actually vaginal laxity or looseness, but your partner probably won't notice. And we actually recently did a study where we asked patients, had your partner ever commented, and most partners didn't. Interestingly, the degree of prolapse is not correlated with sexual function. So I have some patients with a very advanced prolapse who have no sexual complaints and others with fairly minor prolapse who are pretty bothered. And the next big thing to mention is that treatment helps. So pelvic floor exercises can help. In addition to strengthening the pelvic muscles, so the prolapse kind of sits higher up, they also can help with vaginal tightness, which can increase sexual sensation. Patients who choose a pessary can still engage in sex, and most pessaries can be removed for sex by the patient themselves. And in fact, the prolapse actually will stay in for a little while right after the pessary is removed. And if a woman is concerned that the prolapse might fall back down after removing the pessary, what she can actually do is try to engage in sex while lying on her back, since the prolapse is less likely to come down in that position. And the last thing to discuss is sexual function with surgery. And in general, sexual function improves after surgery for prolapse. The part of the surgery which can affect sexual function the most is actually the rectocele repair, or fixing the back of the vagina. And the surgeon can sort of narrow the vagina, which can help correct a feeling of vaginal looseness. But if the vagina gets narrowed too much, that can actually cause patients to develop painful sex, which is called dyspareunia.
5-minute warning.
The truth about sex, and especially sex after menopause, is that vaginal dryness can really affect that. And so as Dr. Wienerman mentioned, vaginal estrogen can be very helpful. As I segue into the portion of the talk on incontinence, I want to mention that incontinence can happen during sex too. So you shouldn't be embarrassed to discuss this with your doctor. While increased vaginal fluid is normal during sex, and some women will even experience a squirting with orgasm, urine loss is not normal, and there are things we can do to treat it if it's bothersome. So let's talk about incontinence for urine leakage. There's both stress incontinence or urge incontinence. So stress incontinence is leaking with coughing, sneezing, running, lifting, basically anything that uses the abdominal muscles. Some patients don't even notice when they're leaking, but then they find that they're wet later in the day, and that usually ends up being stress incontinence too. What are the treatment options for this? Well, the first step is always conservative management. So we start with those same exercises that I mentioned before. Again, it's a squeeze and lift of the vagina as if you were trying to bring it up to your belly button. And if that doesn't work, you can move on to a procedure like a bulking injection or a sling procedure. Here's an image of a urethral bulking injection. You can see before the injection that the patient does not have good coaptation of the urethra, which is to say that the hole where the urine comes out is too wide. And the bulking injection is basically injection of a filler around the urethra to make the hole smaller so the urine is less likely to leak out. And this can be done just with numbing medication in the office or with sedation in the operating room. And these typically last like 1 to 2 years. If a patient wants something more permanent, they can do a sling procedure. I like this image because it sort of explains where the sling goes and what it's doing. Stress incontinence is leakage of urine with increased intra-abdominal pressure, and that's due to a weakened or torn urethral support ligament that you can see here in the photo on the left, or the image on the left. So it sort of makes sense that you can then replace that torn ligament with a sling. And a sling is made of that same plastic fabric or mesh that was used for prolapse, and it has over 20 years of safety data. And the FDA notification specifically stated that no conclusions could be made about slings. And the big difference here is, although they are placed transvaginally, they're much smaller than the mesh placed for prolapse, and they're not exposed to the same mechanical load as mesh placed for prolapse. Basically, they only need to hold the urine in when you're coughing and sneezing, so they're not under tension, and so that's why they have a lot fewer complications. Let's move on to overactive bladder and urge incontinence.
2-minute warning.
Is feeling like you need to pee frequently, and urge incontinence is when you're rushing to the bathroom and you don't quite make it in time. Step 1 is behavioral modification. Drink less, especially coffee. Everyone thinks there's an 8 glasses of water rule, but the truth is, drink when you're thirsty. Your body is pretty good at telling you if you need more fluid. 1 cup of coffee is usually okay, but if you're drinking 4 cups of coffee and rushing to the bathroom, I think you should probably cut way back. The other thing is to think about is, how often are you going to the bathroom? Sometimes you get in a bad habit of going to the toilet just in case, and let me just go in case and let me go again. And if you go over and over again, you basically tell your bladder that maybe it should be going every 30 minutes. And so you actually have to train your bladder to not try to go every 30 minutes and little by little stretch it out so that you're not going so frequently. Just like you would tell a child to hold it if they had gone just a few minutes ago, you need to train your bladder to hold it if you've gone just a few minutes ago. But if you're still bothered after trying these things, the next step is medication. Here's a list of medications used to treat overactive bladder, and they work by relaxing the detrusor or the bladder muscle. There's basically 2 kinds of medications. There's the anticholinergics, and they've been around for a while, and there's a lot of different kinds, but they have side effects like dry mouth, dry eye, constipation, and even confusion in the elderly. The other kind of medication is called the beta agonist, and there's only one of these, which is called Myrbetriq or mirabegron. And it doesn't cause any of those bothersome side effects with the other medications, but sometimes it can make the blood pressure go up. But what do we do when the medications don't work? There are basically 3 options. The first is percutaneous tibial nerve stimulation. And this is an acupuncture-like treatment where an acupuncture needle is placed into the ankle to stimulate the same nerve that goes up to the bladder to help relax the bladder. And the patients come in every week for 12 weeks for about a half-hour session. And if they have improvement with that, they'll then come in once a month for a monthly maintenance treatment. This is the least invasive option, and it's a great option for patients who have the time to do it. The next option is Botox. And this is the same Botox that's used to relax the wrinkles in the face, but when it's injected into the bladder, it helps to relax the bladder so you don't have to go to the bathroom as much. The downside is if it works too well, you might have trouble peeing. It doesn't last forever, but if you had trouble peeing, it might last for a few weeks. And the Botox itself is going to last for probably about 6 to 9 months, and then you would need a repeat injection. The last option is sacral neuromodulation. I like to explain this to patients like a pacemaker for the bladder, because if the bladder squeezes too much or it isn't squeezing enough, this is a great option. It also helps for leaking stool. And it's done as a 2-part procedure. So you get to try it out, which can be done in the office or the operating room. But if it's helpful, then you can actually have it implanted so that you don't have to worry about this. And you just have a battery that needs to either be recharged or changed every few years. So in summary, prolapse is when the pelvic organs fall into the vagina and you have a vaginal bulge. There are a lot of treatment options which range from pelvic floor exercises to surgery. And there are different kinds of incontinence. There's stress incontinence, which is when you sneeze and a little pee comes out, or there's urge incontinence when you're running to the bathroom and you don't make it in time. And there are great treatments for both. The biggest thing I want you to take home is that prolapse and incontinence are pelvic floor disorders, and they're not just part of normal aging. So if you're bothered by these things, you should see a doctor because there are a lot of really good treatment options. There's no age that's too young or too old to treat pelvic floor disorders. And by seeing a specialist, you can help find the right treatment option for you. Thank you.
Thank you so much, Dr. Polland. We will now be starting our Q&A. All right. So our first question is directed toward Dr. Kingsberg. How do we get a Milli, and do I need to ask my GYN first?
The answer is no, you don't need to ask your GYN first, although I would strongly recommend you talk to your GYN about some of the symptoms you might be having that you would want the dilator, but dilators are not by prescription. And the easiest way is online, and it's milliforher.com. So it's milliforher.com. Easiest way, I can spell her, milliforher.com.
Thank you. I would like to remind all the attendees to please make sure that your question is anonymous. Otherwise, I will delete it. All right. So this next question is for Dr. Wienerman. Do 50-year-old women need to stop birth control options if they still get their period regularly?
That's a great question. And I do apologize. I had to cut one slide out for time, but actually it was addressing this very question. So how long should you stay on birth control? When should you reasonably feel comfortable that you won't get pregnant? So in general, fertility is unlikely between the ages of 45 and 49, but it's still possible. Especially if you're getting a regular period, we say that women should probably stay in contraception until around age 50. Fertility is very unlikely after the age of 50. So we recommend that women consider stopping birth control at that point. And if you're symptomatic from perimenopause, that's a time when you can start hormone replacement therapy. If you're still getting a regular period at age 50, it's very unlikely that you would conceive. So you can talk to your doctor about it, but you likely do not need contraception. There have been women who have gotten pregnant after the age of 50. So if you feel more comfortable staying on it, you can. It's controversial whether birth control pills would be safe for you at that point. So it's definitely something to talk to your doctor about. But for most women, the age of 50 is when we would say it's reasonable to stop.
Thank you. Dr. Polland, what is balloon therapy for incontinence?
I'm not sure I know what balloon therapy is referring to. I don't know if there's any further follow-up from the question asker. I'd be happy to answer it if I'm just not sure exactly what you're referring to.
Okay, thank you. My next question is, can you use a pessary for rectal prolapse? Is surgery suggested for rectal prolapse for someone who hasn't had children yet? I'm also going to be sharing my screen so that people remember to fill out the post-webinar survey at this time.
So I'm going to answer that question by reminding everyone that rectal prolapse is basically prolapse of the rectal mucosa through the anus. So the prolapse is coming down through the anus, whereas a rectocele is the prolapse of the rectum. It's basically, instead of the rectum falling backwards, it falls forward. And so the rectum falls down into the vagina. And so there is no pessary for rectal prolapse, but a pessary can be used for a rectocele, which is, again, the rectum falling down into the vagina. Sometimes it's harder to find the right pessary. And sometimes I have trouble finding the right pessary that a patient can use and remove on their own for sex. And for patients who can't be fit with the pessary, or patients who have rectal prolapse, again, that's prolapse of the rectal mucosa through the anus, then surgery can be a good option. I'm not sure if I answered all parts of that question.
I think that was great. All right, I'm going to stop sharing so I can get the next question, and then I'll go back to it. Okay. Should hormone replacement therapy be used for someone who's at risk for breast cancer, or no, Dr. Wienerman?
Excellent question. So when you have an increased risk of breast cancer, that is one of the times when hormone replacement therapy may not be recommended. So women who have had breast cancer should likely not be on hormone replacement therapy. If you are at elevated risk of breast cancer, it depends why, if it's just based on family history or if you have a genetic predisposition. So that is something that your doctor can help you calculate. There are online risk calculators, and there are different recommendations based on how high your risk is. But for many women who are at risk of breast cancer, hormone replacement therapy may not be recommended. It just depends on what the increased risk of breast cancer is due to. So that's why I said individualized decision-making with your physician based on what that level of risk is.
Thank you. All right. How long do hot flashes last? Like how many years? We have someone who's many years post-menopause and still dealing with it.
Excellent question. So like I said, for some women, they do go away within 5 to 10 years. For others, they can last for 20 years. And we don't know exactly why they last for some women much longer than others. So the answer is, yeah, 12 years post-menopause to still have hot flashes is not uncommon. And that's why the recommendation for hormone replacement therapy is ideal duration of use 5 to 10 years. But for some women, that's not going to be enough to cover their symptoms. So for some women, they do need to maintain, if there are candidates for hormone replacement therapy, longer than that 10 years. Obviously, if women are not candidates for hormone replacement therapy, other therapies to manage. But unfortunately, I wish I could say that hot flashes go away sooner, but unfortunately, that's not uncommon.
Okay. Dr. Polland, can a pessary for uterine prolapse be used for a long-term treatment?
Yes, so I definitely have patients who prefer a pessary, and I think that if you're not sure that you want surgery, a pessary is a great first option, because you could try a pessary and say, this is great, I like it, and I never want to go on to surgery. Or you could try a pessary and say, this is not for me, and now I'm sure that I want to go on to surgery. So if someone's not sure, I think a pessary is a good choice. And for somebody who is comfortable with the pessary, you can, continue with the pessary for the rest of your life. You may need to change the pessary over time, partially just because, they get, old and you need to wash. I mean, you wash them regularly, but you may need to replace it, but also because the prolapse may change. And so you may need to be refit with the pessary. When you get a pessary, you don't just, go buy one on Amazon. You go to your doctor's office and you get fit with one. It's almost like going to a shoe store where you try on different sizes and shapes, and then you pick the one that's right for you. And some doctors will send you home with it, or some doctors will then give you a prescription that you can take to a surgical supply store. But there are a lot of different pessary options, and they can be a great option if somebody wants to keep that for a long term.
Excellent, thank you. Also for you, what's the name of the 12-session stimulation therapy you mentioned for urgent incontinence?
So it's percutaneous tibial nerve stimulation, or PTNS is the way that it's often referred to. And so I'm sure if you ask your doctor about that, they'll be able to tell you more about it.
Thank you. What would be a suggestion for someone who's premenopausal and experiencing vaginal dryness?
That is an excellent question. I'm actually really happy that you asked that question, whoever it was, because premenopausal vaginal dryness is extremely common. So you can get it for a variety of reasons. And, hormonal fluctuations premenopause are very common as well. So if it is something that, can be associated with low estrogen levels for a variety of reasons, not necessarily premenopause, local vaginal estrogen can be indicated for many women during their reproductive years. So I prescribe vaginal estrogen for many of my patients who are premenopausal. So it's definitely worth discussing with your doctor if it's something that can be beneficial. If it's not related to hormonal changes, then like moisturizers or lubricants can be potentially beneficial depending on the etiology. But it is very important to understand that estrogen changes in the vagina can occur premenopause as well.
Thank you. Dr. Pollins, can you address postmenopausal UTIs? And does that have anything to do with intimacy? Or can you also address UTIs associated with intimacy?
So UTIs are often associated with intimacy. I have a lot of patients who get UTIs immediately after being intimate, and the good advice for preventing UTIs in general is to drink plenty of fluids and make sure you're urinating regularly. There's never been a good study to say that going to urinate after having intercourse is the best thing to do, but it just isn't that hard, and it's probably a good idea. The other thing is sometimes I'll start patients on an antibiotic that they just take right after they have intercourse. And so it's sort of to prevent, it's not enough to treat a UTI, but it prevents the UTI from happening because it just sort of kills the bacteria before it has a chance to stick to the walls of the bladder. In terms of menopause, this is actually going back to Dr. Wienerman's topic, which is vaginal replacement of estrogen, because the problem with menopause is that the vagina gets dry, and then the good bacteria can't grow and the bad bacteria grow and you get a UTI. It just makes it easier for the bacteria to cause a UTI. And so by replacing the vaginal estrogen, it actually creates a situation where the good bacteria can grow and kind of prevent the bad bacteria from getting in and causing a UTI. It is difficult for patients who can't use vaginal estrogen for whatever reason. And we're actually doing a study now at Maimonides, and we're hoping to open it up throughout Northwell Health, looking at vaginal testosterone. So for patients who can't use estrogen, for various reasons, there's been evidence to show that vaginal testosterone can be helpful for the genitourinary syndrome of menopause, basically that dryness, but nobody ever looked to see if it would help prevent UTIs. So that's what we're doing now, is we're saying, well, if it helps with the dryness, it might also help with the UTIs. And we're looking at that now in a randomized controlled trial.
For Dr. Wienerman, are there any changes or differences in menopausal symptoms for women who have childbirth later in age? For example, after 35 or so, does perimenopause change in ages with this?
That's an excellent question. There are many things that are associated with age of menopause. Mostly we think it's genetic. So, what's predictive of what age you're to go into menopause is how old your mother was when she went into menopause, or how old your other relatives were. We do not think that things that, mostly you don't think that things that happen during your life are really that predictive, because your age of menopause is really set by the eggs that you have at the time of your birth, and then how quickly those eggs get depleted. So really, it's probably based more on your genetic factors and what kind of how you're programmed, more than more things like pregnancy. There are certain conditions that are associated with later age of menopause. For example, PCOS. I don't know how familiar the audience is with PCOS, which is a hormonal condition that tends to be associated with later menopause. But other than that, it seems to be other causes, not specifically pregnancy.
Excellent, thank you. I'm going to ask a couple of more questions and then we'll wrap up. How often do you need a GYN exam postmenopausal with or without a uterus? People also mentioned after age 65, the Medicare coverage, etc. So we'd like your thoughts on that.
Good question. I did see that question. So I think the most important aspect of this question is a contact with a physician regularly. You know, if Medicare is not paying for that with a gynecologist, I think that a primary care physician is reasonable. I do think that there are issues that are specific to a gynecologist that I would like to be addressed yearly, but I think that, you know, that there can be that contact with a with a primary care doctor yearly, and then if things do arise that you feel that you need to discuss with a gynecologist, then you can make an appointment. So I don't want to, you know, question what Medicare is doing. I don't think you necessarily need to pay for a visit if you don't need one, but regular contact with the physician yearly, I think would be appropriate. As I said, you don't need a pap smear after age 65. So that's maybe why they're not recommending those visits annually, but you still need gynecological care. So it's important that you do make an appointment with a gynecologist if you have symptoms that need to be discussed, and then you also have a primary care doctor that you feel comfortable discussing these issues with, who can refer you to a gynecologist if needed.
Thank you. Okay. And are there any risks or side effects of vaginal estrogen creams?
That's a great question. So there are some risks. The absorption of the cream into the bloodstream is very small, but there is a little bit. So for women who, you know, cannot have any estrogen exposure, you know, their doctors might tell them that they cannot use vaginal estrogen. So that is one thing that should be discussed with your doctor. Estrogen cream can cause irritation or allergy in some patients. So the cream itself can, you know, cause some side effects. I think the main concern would be women who cannot have estrogen at all. Like I said, for most women who have contraindications to hormone replacement therapy, vaginal estrogen would still be okay because the hormone level is so low. For example, we talked about it a little bit, but, you know, estrogen, general hormonal therapy causes an increased risk of blood clots. So women who are high risk of blood clots could still have hormone replacement therapy with vaginal estrogen because the absorption is so low. Now, women who've had a history of breast cancer that's estrogen sensitive, that's a question that would need to be discussed with their doctor if they're okay with them having vaginal estrogen or not. For some cases, it may be yes, and other doctors might still say no.
Thank you. All right. And why don't you need a pap smear after age 65?
Excellent question. So there's a lot of reasons. The main reason I would say is if you've had regular pap smears your whole life, then your chances of having cervical cancer develop in your lifetime, if you've had normal pap smears up until age 65, is very low. So cervical cancer develops from, we now know, something called HPV, human papillomavirus, and it takes a long time to go from human papillomavirus infection to precancer to cancer. So if you're 65 and you've not had a history of human papillomavirus infection, then your chances of getting cervical cancer are extremely low. Now, there's one caveat. If you have a new sexual partner or have new risk factors for getting HPV infection, that's something that can be reconsidered. But for most women, if you've had negative pap smears up to the age of 65, your chances of having a new HPV infection and then getting enough of an infection to then have a new cervical cancer develop in your lifetime are very, very low.
Great. Thank you so much. So I'd like to wrap up. Thank you so much to all of our speakers, Dr. Kingsberg, Dr. Wienerman, and Dr. Polland. Thank you to all of our attendees for joining JOWMA's webinar about menopause. Again, thank you to the speakers for educating us about such important topics. And I also really want to thank the Women's Health Committee at JOWMA, Sahar, Miriam, Jackie, Nicole, and Tamar for organizing such a great event. And stay tuned for our next one. Thank you so much and have a great night, everyone.